Hello, my name is Zoe Mariño. I work in the liver unit, Hospital Clinic in Barcelona, Spain. I have been asked by the editors to talk about our article recently published in Journal of Hepatology, assessing intravenous silibinin monotherapy in the liver transplant setting. As you know, liver transplantation, LT, is the treatment of choice for HCV-infected patients with end-stage liver disease or hepatocellular carcinoma. Unfortunately, infection of the graft occurs immediately after LT in viremic patients, and fibrotic progression is extremely accelerated after LT. The goal in the peri-transplant period is to prevent HCV recurrence, eradicating the virus before LT. But unfortunately, patients in the waiting list are a difficult population to be treated, since interferon is contraindicated in decompensated cirrhotics. In a whole, HCV recurrence after LT will only be prevented in 10 to 20% of potential candidates enlisted for transplantation. Another potential strategy is to treat patients after LT once recurrence has occurred. However, interferon cannot be used immediately after surgery, adverse events are common, and pharmacological interactions with immunosuppressive treatment are an important issue to keep in mind. Silibinin is a natural flavonoid which has been used for centuries as an hepatoprotector. It has shown antioxidative, anti-inflammatory, and antifibrogenic properties both in vitro and in animal models. Dr. Ferenczi in Vienna showed in 2008 the potent antiviral properties of SIL when used in previous non-responders HCV-infected patients, and after that 2 reports have showed the prevention of HCV recurrence after LT by using intravenous silibinin monotherapy in 2 patients, although both of them had low viral load and were genotype 3 and 4. Silibinin is thought to act by a mixed mode of action: inhibition of NS5B polymerase, interference on viral entry, and interaction with the viral NS4B. Based on this data, we decided to explore the safety profile and the antiviral efficacy of SIL in a cohort of HCV-infected patients with end-stage liver disease awaiting liver transplantation. The study was prospective, randomized, double-blind, and placebo-controlled, and the main objective was to assess whether intravenous silibinin infusion was able to avoid HCV infection of the graft. Patients were randomized to receive 20 mg per kilo per day silibinin or placebo according to a 3:1 ratio until LT was performed, or for a maximum of 21 consecutive days before LT, and this was the pre-LT treatment period. After LT, patients received treatment for further 7 days of silibinin or placebo, starting on the same day of the surgery, and this was known the post-LT treatment period. Afterwards, patients were followed up for 24 weeks after LT to assess SVR. Infusions were administered daily in the hospital over 2 hours, and viral load was assessed at every visit by real-time PCR. 16 patients consented to participate, and 14 of them were randomized. 12 out of the 14 randomized patients were treated for 14 days or more in the pre-LT period, and they were considered the eligible population to assess virological efficacy: 9 patients in the SIL group and 3 patients in the placebo group. 11 patients of the cohort underwent LT, but only 10 completed the 7 days of treatment after LT, and these were the patients which constituted the intention to treat population for the efficacy analysis. Let's consider the results of the pre-LT period first. In the 9 patients in the SIL group, the median viral load decrease from baseline to the end of the pre-LT treatment was 2.31 log, and significantly different from the 3 patients of the placebo group, which was 0.3 log. In addition, 6 out of these 9 patients in the SIL group achieved a more or equal to 2 log decrease in viral load at the end of the pre-LT period, which in the study was defined as partial virological response. As expected, no patient in the placebo group behaved equally. Moreover, viral load in 2 patients in the SIL group was below the limit of quantification, and in one of them below the limit of detection. As you can imagine, accurate prediction of the time of liver transplantation for these enlisted patients was an important limitation of the trial. and in fact only 3 patients, all of them in the SIL group, underwent LT while on therapy. In those patients in whom there was a gap until LT, as expected, viral load rebounded in most of them. After LT, viral load was significantly lower in all the 7 days of therapy in the SIL group compared to placebo. At the end of the post-LT phase, all 7 patients receiving SIL showed a partial virological response, with 2 patients being even undetectable. Of course, these results were not observed in the placebo patients. Unfortunately, viral load increased after the end of the short post-LT treatment in all patients, so none of them achieved SVR. In terms of safety, 75% of the adverse events were mild and were similar to previously described symptoms: heat sensation, chill, abdominal pain, diarrhea, or a reversible increase in bilirubin levels. No pharmacological interaction related to SIL was observed in the post-LT phase. Of course, we are aware of the limitations of the study, mainly the small number of patients included in the trial, the impossibility of knowing in advance the day of the procedure, and the need of an uncomfortable daily infusion in the hospital. However, with all the information, and despite the fact of not achieving the study aim, which was SVR, we can certainly give 2 important take-home messages from our results. First, we confirmed the potent antiviral activity of intravenous silibinin monotherapy in difficult-to-treat patients awaiting liver transplantation and after liver transplantation. 2/3 of silibinin-treated patients in the pre-LT period and all the patients in the post-LT phase showed 2 log decrease or more in viral load, and in 2 cases viral load was even undetectable. Second, we confirmed good tolerability of the drug and a good safety profile of SIL monotherapy, not only in decompensated cirrhotics awaiting liver transplantation, but also in the very immediate phase after LT, and no pharmacological interactions were observed in this phase. So can we improve our results somehow? Indeed, maybe the main problem of the study was the need to stop SIL when reaching day 21 pre-LT, based on the safety data of the company when designing the protocol. Not surprisingly, almost all these patients who had a gap until LT showed a virological breakthrough to previous baseline levels. We certainly think our results can be improved by other therapeutical schemes, either using the pre-LT treatment when LT data is previously known, such as in living donor liver transplantation programs, or by extending post-LT treatment with silibinin during hospitalization after LT and starting from the anhepatic phase. The duration of this treatment still has to be assessed, but 3 or 4 weeks seem a reasonable option. Moreover, the antiviral activity of SIL, along with its tolerability, makes SIL a potential good option to be used in combination with other direct antiviral agents, and it could also be considered in the future as a leading phase to decrease viral load before starting interferon-free oral combinations soon after LT. Despite its obvious problems, such as intravenous route, daily infusion, or need to be given in the hospital, I certainly think SIL may be a good antiviral strategy in some circumstances. LT patients would be the best candidates for SIL, starting early after LT and kept as long as hospitalization lasts. It is excellent profile, and the fact of not interacting with immunosuppressive therapies must be also kept in mind. And of course, an oral combination for silibinin would also be a great contribution to the huge box of future options of oral antiviral therapies in these patients. Thank you.